Okay, so this is part 2. So the REPLACE 2 study was one of the first trials looking at a direct thrombin inhibitor, bivalirudin, in PCI patients, and it was the largest trial ever conducted. And so essentially, this was patients who were urgent or elective, and these were typically your non-STEMI unstable angina patients, and they either received for their procedure, they all received aspirin, clopidogrel, and a stent, and then they either received bivalirudin, as we talked about before, with the provisional 2B3As, and the provisional 2B3As, if they had like a large thrombus burden, a large clot still, and this is all at physician's discretion. And it's compared to heparin, weight-based at 65 units per kilogram, plus one of the 2B3As of ziximab or eptifibatide. And so these are pretty much low-risk PCI patients. They excluded anybody that was primary or urgent and needed an urgent PCI, such as STEMI. And again, the suggested indications per the provisional 2B3As are listed there. So like the ones I said, new obstructive dissection, impaired or slow coronary reflow, so they didn't get good TIMI3 flow, which is what you strive for when you're trying to open up an artery, and those other things listed there. It's important to remember they also had some key exclusions for bleed risk, so that's something else to think about when you try to compare your patient to this patient population. If they were surgery trauma, or if they've had a GI bleed, they weren't enrolled. If their platelets were low, they weren't enrolled. Or if they were poorly controlled hypertension patients, they weren't enrolled. Another key thing to think about in this study is they were all given that clopidogrel 300 milligram load, and most patients got it greater than 2 hours prior to the procedure, about 56% of patients. So that's what we call preloading clopidogrel. Not all hospitals do that, us being one of those. And the reason for that is oftentimes these patients may require surgery urgently after a cath. And if you've loaded them with Plavix, then you're going to have a big bleeding mess on your hands once they go into the OR. So at our hospital, we typically don't preload Plavix. We do occasionally, but we typically don't. So that's important to keep in mind, because these studies, for the most part, and especially REPLACE 2, the patients had had a Plavix load greater than 2 hours prior to the procedure. So Plavix had plenty of time to have its onset. So they looked at a quadruple endpoint, basically looking at death from any cause, MIs, urgent revascularization, and major bleeding. Major bleeding was intracranial bleeding, retroperitoneal bleeding, overt bleeding with a decrease in hemoglobin of greater than 3, essentially. And if they didn't observe a bleed, but the hemoglobin was greater than 4 drop, that was considered a major bleed as well. Again, this is just kind of repeating what I said earlier, antiplatelet therapy that was used. So majority of patients got clopidogrel. Ticlopidine was the only other one available at that point. And you can see what I was talking about here. The duration of pre-treatment, 56% were on it 2 to 48 hours before randomization. And so then almost all of them got it post-procedure. And then of the patients that were planning on getting 2B3A inhibitors in that arm with the heparin, majority got eptifibatide. And then it's important to note here for provisional 2B3A inhibitor use, so 7.2% of the bivalirudin group ended up getting provisional 2B3As. So that was, again, for those patients that had a large thrombus burden, dissection, something like that. And they're about equal in both types of 2B3As. So these are the endpoints at 30 days. And so essentially, Angiomax with provisional 2B3As was shown to be superior to the imputed heparin group alone. And it was non-inferior to the heparin plus 2B3A inhibitor group. So heparin by itself, better, but with the 2B3As, no difference. There was no significant differences between any components of that quadruple endpoints, except for major bleeding, which was significantly reduced by 41% in the Angiomax group, that even with the provisional 2B3As. The only component of the composite endpoint that was numerically but not significantly increased in the Angiomax group was the non-Q wave MI. So again, no difference in the primary endpoint, but there was definitely a difference in major bleeding. It was lower in the bivalirudin group. So that's just something to keep in mind, and you may see that as a theme in these other studies. This is kind of just splitting up the hemorrhagic endpoints. So again, the remember the bleeding definitions we had said was intracranial bleeding, RP bleeding, overt bleeding with hemoglobin greater than 3, or if you saw a drop of hemoglobin greater than 4. And this is just different than the TIMI major definition that we use in a lot of other historical trials. So that's just something to keep in mind as one of the critiques of this study. So again, bivalirudin with provisional 2B3As definitely having a much different and significantly different rate of major bleed, minor bleed, TIMI minor bleed, axis site bleed, and then the platelets dropping less than 1,000. These are the 6-month ischemic endpoints. And so you can kind of see from the 30-day outcomes we talked about earlier, there really wasn't any difference that came about at the 6-month point either. Those lines kind of stay similar, and there's no difference in the p-values. The 1-year mortality, so the key point here that at 30 days there's a 0.2% difference in mortality between the two groups, and this was again confirmed at 1 year with a 0.6% difference, a little bit lower in the Angiomax group, but again, no significant difference here either. This is just briefly kind of going back through what I said with the clopidogrel. And so again, remember how many people got it in the study. There was a lot of patients that got it in the study. And so those are the patients that are either in the yellow or the kind of purplish box colors that got pre-treatment with clopidogrel. And so essentially you can see that the quadruple endpoint and the triple endpoint, it was bivalirudin pre-treatment was better than no pre-treatment compared to each other, and bivalirudin was better than heparin in the bleeding arm, but not in any of the quadruple or triple endpoints. So this again underscores the importance of how the pre-treatment played a role in this study, giving Plavix preloaded. So controversies from this study. It was a non-inferiority study. Primary endpoint included efficacy and safety. That's not something you typically see. We typically see bleeding split out into more of a safety endpoint. And there was increased ACT values with heparin versus the previous 2B3 inhibitor studies. 317 seconds was the average, but we typically shoot for around that anyway, so I don't really take that as much of a controversy. And then what we said about the increased non-Q-wave MIs. The next biggest study for bivalirudin that was similarly set up as their place study is the Horizons AMI. And the big difference in this one is it's only in the STEMI population, so these were patients that did require urgent PCI. Same kind of setup, same infusions, and they still allowed the provisional 2B3As in this study as well. And all patients received aspirin and Plavix, and they could get a preload, and then they got 75 milligrams daily. So one thing that should stand out to you in this study is, again, the clopidogrel, the use of it, and the loading of it. So 60% in both arms got the 600, about 37% got the 300. They didn't give us much information about the time of preloading in this study. We do know that several patients were preloaded, but we don't exactly know the timing. So that's important to remember compared to the Place 2 study as well. So when you look at the outcomes in this study, again, they looked at this net adverse clinical events because I'm assuming they knew that bleeding was probably going to be something that made a difference, so they wanted to be able to say they hit their primary endpoint. And so they found that bivalirudin was better than heparin plus 2B3A inhibitors, but when you broke out kind of some of the endpoints, nothing was significant except for bleeding again, so like no difference in any of the ischemic outcomes. That's important to remember. And I do have the data actually for clopidogrel preload. So essentially 30% received a 300 milligram load upon admission before going to the cath lab, and 60% received a 600 load. And the reason that's important for us is because we typically run bivalirudin till end of case. Past end of case, and all of these studies ran it till end of case. And so the reason they could stop it at the very end of the case in the cath lab is because they already had their Plavix on board. Most of the time in our cath lab, we're giving the Plavix at the end of the procedure once we've seen the anatomy, and so you may not have time for it to have its onset. And so we often overlap the bivalirudin and run it a little bit longer than end of case. This is just kind of reiterating some of the results. So again, no difference in the major adverse cardiovascular events. You do see a difference when you add in the death from cardiac and non-cardiac causes, with bivalirudin having a significantly better results for the cardiac causes. But one thing to keep in mind down here is acute stent thrombosis, which essentially means the stents quickly occluded, was much higher in the bivalirudin group, and it was significantly different. So this may have been some of those patients that maybe weren't preloaded on Plavix, and when they stopped the bival at end of case, they ended up having acute stent thrombosis. I'm just going to Acuity, another ACS study in some patients undergoing early invasive strategy that used bivalirudin. And so I'm going to quickly go through this so we can get to the other stuff. And this was a newer study, that I'd added in last year about bivalirudin use upstream prior to PCI. Would it be helpful to start this essentially in transfer to the institution? And they gave similar doses what we were used to for 4 hours post PCI, and they started it 2 hours before the PCI. And they also started heparin or Lovenox before the PCI. And we often see that happening anyway when they are being transported. And they could use PTY12 inhibitors such as Plavix, and they could use 2B3 inhibitors as well. And so essentially using it upstream, we found that bivalirudin had less death or non-cabbage major bleeding, and then they had less, and then again that kind of held when they added it as a secondary outcome. But when you looked at death from cardiac causes and non-cardiac causes, again, no difference there. So again, the bleeding drove that primary endpoint. And then you see the same theme with stent thrombosis, that the bivalirudin group actually had more stent thrombosis. So you question if they should ever be stopping this at end of case and maybe thinking more like we do and running it a little bit longer past the end of the case. That's just the bleeding outcomes, so you can look at that. I'm going to skip through acuity. So just as a reminder from these studies, these are kind of the combined list of indications for provisional GP2B3 inhibitors. So decreased TIMI flow, slow reflow, dissection, new thrombus, persistent residual stenosis, having a distal embolization, unplanned stent, side branch closure, anyway that's clinically unstable or prolonged ischemia. So sheath removal, band loosening, that'll be a question that you get when you use bivalirudin, because you can't check like ACTs as quickly as you do with heparin to see when you're good. So essentially, if they have normal renal function and you stop the drip, you just need to pull the sheath 2 hours after completion of the infusion. And the sheath, remember, is where we actually put the catheter in that we're using to inject the dye. So it's such a quick half-life. If they're normal renal function, you can go ahead and stop it and pull the sheath out after 2 hours. If they're dialysis, you need to check an APTT 4 hours after they stop it, and once it's less than 50, you can pull the sheath then. And then if it's a radial procedure where you're going in through your radial artery, they use these bands basically in those sites, and essentially you can loosen the device 45 minutes after the infusion has ended and monitor the patient for bleeding, and then just keep kind of loosening every few minutes after that 45-minute mark. So where does it fall in the guidelines? So essentially, in the ACC, AHA, unstable angina, and STEMI guidelines, it basically says you can omit 2B3 inhibitors if bivalirudin was selected as the anticoagulant and at least 300 milligrams of Plavix was administered at least 6 hours earlier. So that's where that preload really comes into play. If they've received heparin, they'd like you to wait 30 minutes and then start with the same dosing we talked about, and that's just because of risk of bleeding with giving them at the same time. STEMI guidelines, this is what they say. So it's a 1B recommendation, and without any treatment of heparin previously, and you can also give additional bolus if you don't reach the ACT you need. And then it says it's preferred over heparin with 2B3 receptors in patients at high risk of bleeding only, and that kind of speaks to the bleeding endpoints we talked about, and that's a 2A recommendation. So the next part we'll be getting into direct arm inhibitors and HIT, and I'm going to pause it now so that we can save this 15 minutes.